Welcome back to my channel. Today we are talking about thorax radiographs positioning. So, thorax radiographs are a crucial diagnostic tool for veterinarians to assess the health of a pet's chest cavity, including the heart, lungs, and other structures. Proper positioning is essential to obtain clear diagnostic quality images. So let's dive into first thorax positioning guide. Thorax lateral view. Patient is in lateral recumbency. Both right and left lateral views are recommended for a complete study. Thoracic limbs are pulled cranially. Avoid overstretching the patient. Sternum and spine are aligned in the same horizontal plane, parallel with the image receptor. Place a foam vase or a towel under the sternum to correct rotation. Measure the thickest part of the thorax, usually over the liver. X-ray beam is centered on the heart or caudal edge of the scapula. Field of view (FOV) is collimated to include the entire bony thorax from thoracic inlet to last ribs. Make exposure at peak inspiration. You can see the right lateral view of the thorax in the radiographic images. Thorax ventrodorsal view. Patient is in dorsal recumbency. Thoracic limbs are pulled cranially. Avoid overstretching the patient. Sternum and spine are superimposed in the same vertical plane, perpendicular to the image receptor. Head and neck are in line with the spine. Measure the thickest part of the thorax, which is usually over the liver. X-ray beam is centered on the heart or at the caudal edge of the scapula. Collimate the FOV to include the thoracic inlet, outer edges of the ribs, and the last ribs. Make exposure at peak inspiration. The picture shows the ventrodorsal view of the thorax. Next, thorax dorsoventral view. Patient is in ventral or sternal recumbency. Elbows and stifles are slightly abducted, and pelvic limbs are in a crouching position for the patient's comfort. Sternum and spine are superimposed in the same vertical plane, perpendicular to the image receptor. Head and neck are in line with the spine. Measure the thickest part of the thorax, usually over the liver. X-ray beam is centered on the heart or at the caudal edge of the scapula. Collimate the FOV to include the entire bony thorax from the thoracic inlet to the last ribs. Make exposure at peak inspiration. The radiograph shows the dorsoventral view of the thorax. Next, thorax ventrodorsal view with limbs pulled caudal. This is a supplemental radiograph of the thorax made in addition to the standard lateral and VD or DV views. Patient is positioned for a VD view of the thorax as described. Thoracic limbs are pulled caudally instead of cranially. The radiograph shows the VD view of the thorax with the limbs pulled caudally to eliminate superimposition of the scapula and associated musculature on the cranial thorax. Next, thorax ventrodorsal oblique view. This is a supplemental radiograph of the thorax made in addition to the standard lateral and VD or DV views. Patient is positioned for a VD thorax. Sternum is rotated to the right or left to better visualize the area of interest by eliminating superimposition of the heart, spine, and sternum. X-ray beam is centered on the area of interest. Collimate the FOV as per the VD view. Make exposure at peak inspiration. The radiograph shows VD oblique view of the thorax. The sternum is rotated to the right, which enhances visualization of the left lung. The heart follows the sternum. Notice the thoracic dorsal spinous processes project to the left in this view. To name an oblique view, we describe the path of the X-rays. For example, a Divan 5R VLO view means the X-rays pass through the thorax from dorsal 15-degree right to ventral left obliquely. In simple terms, the patient was in sternal recumbency, DV views, and rotated 15-degree to the left. Next, thorax craniodorsal caudoventral view, also called skyline view. This supplemental radiograph of the thorax is made in addition to the standard lateral and VD or DV views. Patient is in ventral or sternal recumbency with the thorax limbs extended. Head and neck are hyperextended. Avoid excessive tension on the neck as this can distort the shape of the trachea. Thickness is measured from the thoracic inlet to the ventral thorax. Increase the X-ray exposure. Double the MAS or increase the KVP by 20% over what is listed in your technique chart for this thickness of thorax. X-ray beam is centered on the thoracic inlet. Collimate the FOV as small as feasible to include the bony thorax at the thoracic inlet. The radiograph shows the skyline view of the thoracic inlet. Arrow points to the trachea. Again, this is thorax VD tangential view. This is a supplemental radiograph of the thorax made in addition to the standard lateral and VD or DV views. Patient is positioned for a VD thorax views. Sternum is rotated to the right or left, whichever makes the area of interest perpendicular to the X-ray beam. X-ray beam is centered on the area of interest. Collimate the FOV as small as feasible to the size of the area of interest. This view is not made to image the entire thorax. Rather, it is intended to focus on a specific site or lesion. The radiograph shows the VD tangential view of the thorax. White arrows point to reef fractures. Lastly, horizontal beam radiography. Let's see about the pictures A and C positioning. Patient is standing, held erect, or recumbent, depending on the purpose of the study. A depicts the dog is in right lateral recumbency with the image receptor along its dorsum for a horizontal beam VD view. C depicts the dog is in dorsal recumbency with the image receptor alongside its body for a horizontal beam lateral view. X-ray beam is directed across the table, perpendicular to the image receptor and centered on the area of interest. Set the source to image distance, SID, to the standard SID for your practice, typically 100 cm or 40 inches. Measure the thickest part of the body part being imaged. Collimate the FOV to the size of the area of interest. Now let's look at the radiographic images. Radiographic image B depicts horizontal beam VD view of the thorax. The dependent or down lung is partially collapsed and increased in opacity, and the heart falls towards the dependent side due to the effects of gravity and the collapsed lung. Radiographic view D represents horizontal beam lateral view of the thorax. A small volume of abnormal pleural gas is visible between the cardiac silhouette and the sternum, shown by arrow. Gas rises to the uppermost part of the thoracic cavity. The dorsal lung are dependent, partially collapsed, and increased in opacity. So that's all about the radiographic positioning of thorax.